Here at the BSH in 2019, I had the opportunity to speak about opportunities that we have from understanding more about the genome in lymphoma. This is really interesting, and we have some fascinating, increasing insights into the genomic landscape of the different types of lymphoma. And we're beginning to think about how we might use those insights as ways of treating, of using these as a basis for treatment in the disease. So, for example, in diffuse large B-cell lymphoma, this is a disease that generally we do quite well with conventional chemotherapy, and we can expect maybe 80% of patients to be alive and progression-free 2 to 3 years after therapy when they're in clinical trials, less in the real world. So the bar is quite high for us to be able to identify specific genomic aberrations or specific patterns of genomic aberrations for us to then identify subgroups that are going to do well and less well. And for some 15 years now, we have had two distinct classifications of diffuse large B-cell lymphoma: activated B-cell type and germinal center B-cell type, which have different oncogenic aberrations, bringing about different clinical outcomes, with the ABCs believed to do less well retrospectively than the GCBs. And we've been interested, along with other groups, in trying to identify prospectively patients who have an ABC phenotype and trying to look to see if adding additional therapy to R-CHOP chemotherapy may improve outcomes. Now, one thing we know about the ABC subtype is that it's associated with recurrent mutations in the NF-kappa B pathway. So in the Remodel B study, which we've published actually today, shows that if you add bortezomib to R-CHOP chemotherapy, it doesn't improve the outcome of patients with DLBCL. And we were disappointed to see that it didn't improve the outcome, particularly of the ABC subgroup. Now, we know that other investigators have looked at the use of other agents, including ibrutinib, which may potentially, in a subgroup of patients based upon age, may improve the outcome in DLBCL. And we are interested in a ABC-specific drug, lenalidomide, which is immunomodulatory, added to R-CHOP chemotherapy, which is being investigated in a phase 3 study to see if it improves the outcome in patients, again, with the ABC phenotype. So that's kind of using genomics in terms of potentially trying to change the agents we give patients. Data that's come out in the last year from a number of groups, however, have shown that the different subclassifications of diffuse large B-cell lymphoma is much more complicated. And in fact, there's probably 6 different subgroups of DLBCL based upon whole exome classifications. And within that sort of whole exome-based sequencing, we know that we have patients with recurrent mutations in one particular pathway, or we have patients who have genomic instability as a result of p53 mutations. And we probably have patients with ABC type DLBCL that are good risk, and those patients who are poor risk, and probably the same with GCB. And how we might use these 6 different subgroups now, prospectively in clinical trials, is going to be something that's difficult and challenging for us in trial design. So I also spoke about the group of double and triple hit lymphomas, and these are B-cell lymphomas that have rearrangements of MYC and BCL2 or BCL6. And these are typically associated with a poor prognosis, and we haven't really got therapies that may alter their treatments, except for perhaps using infusional chemotherapy. What we've realized is that actually we can identify a broader group of patients who have a transcriptional profile that looks like they have a double hit or triple hit, but by FISH analysis don't actually have that. And this larger group of patients are really interesting, these high-grade lymphomas which have a poor prognosis. And there's some potential ways into therapeutic targeting of this group of patients. Where we are with follicular lymphoma is we understand follicular lymphoma, the mutational landscape is very much one of sort of mutations in the epigenetic pathways, and we're beginning to see that we might be able to influence that. The EZH2 inhibitor tazemetostat, for example, seems to work much better in patients who have a mutation in EZH2 rather than patients who have wild-type EZH2. And there are a number of different therapeutic approaches to targeting this disease. In T-cell lymphoma, the genomic landscape is complicated, the numbers of patients are very small, the tissue availability is very limited, and we can see that there are numbers of pathways that are dysregulated. However, as yet, we've not been successful in therapeutically targeting these dysregulated pathways. So I think we're at the dawn of some really exciting ways of moving forward in the management of lymphoma based upon the genomics, but we've got a lot of work to do.